I want to introduce you to the Shaul G. Masri Distinguished Award recipient. This lectureship was established to honor Dr. Shaul G. Masri for his scientific achievements and his contribution to the kidney healthcare community and to the National Kidney Foundation. This year's recipient is Dr. Joe Ix of the University of California in San Diego. He's been a tireless leader in clinical research, and his work is invaluable to advancing kidney care. He's been a mentor to many investigators and helps to hone their work. He's truly walking in the footsteps and legacy of Dr. Masri. He's professor of medicine and chief of the Division of Nephrology at the University of California in San Diego. And he's also a staff physician at the Veterans Affairs San Diego healthcare system. His research has really focused on two main areas. The first is understanding the contributions of kidney tubule disease on kidney disease progression and evaluating new approaches to treat kidney disease-related bone and mineral disorders. He has demonstrated the limitations of using biomarkers for kidney disease and for the link between kidney disease bone and mineral metabolism and cardiovascular disease outcomes. He was also an investigator in the SPRINT trial and has received numerous NIH grants to study kidney disease and its link with cardiovascular disease. And he's an incredibly nice person. So let me introduce Dr. Joe Ix.
Thank you, Holly, for that very warm introduction. And thank you to all of you. This is also my first time doing a plenary talk virtually, and I'm deeply appreciative for you attending the talk rather than my ability to be with you in person in New Orleans. On my computer, I see we have over 600 people joining us. And so I very much thank you for your attention. And I look forward to sharing some of our data. So the title of my talk is the Prognostic Insights from Non-Invasive Assessments of Kidney Tubule Health. And I will begin to move through here. Briefly, I wanted to disclose that I'm a principal investigator on a investigator-initiated research project that's sponsored by Baxter International. This study studies different ways of providing peritoneal dialysis on fluid removal and is not directly related to today's talk. Before moving to the content of my talk, I wanted to share how deeply honored I am to be this year's recipient of the Shaul G. Masri Award from the National Kidney Foundation to give this plenary talk. I once had the privilege of meeting Dr. Masri and just wanted to alert the audience to his many contributions. He was a division chief at University of Southern California for over 25 years. And like Dr. Kramer, is a past president of the National Kidney Foundation. He's made many seminal contributions, particularly in the area of calcium, phosphate, and magnesium and PTH regulation, and how those are altered in the setting of advancing uremia. And for this work, really is recognized as an international leader in CKD mineral bone disorders. And because of his advocacy for kidney care and kidney research, really for nephrology more globally. His leadership and advocacy for nephrology research that really matters to our patients has certainly improved our renal community and made it a richer place to live and to work. And so I am deeply honored to be the recipient this year. So the goals of my talk are really to describe an idea that my colleagues and I had maybe 6 or 7 years ago about trying to identify the global health of the kidney beyond EGFR and albuminuria, and understanding the contributions that those measurements may make in terms of understanding consequences of kidney disease, whether it's risk of progression of chronic kidney disease, cardiovascular disease, or other comorbidities, and perhaps also in the long term to be able to monitor kidney disease through new ways. So the talk will really focus on recent data that we have put together, most of it published, some of it still unpublished and appropriately referenced as such in this topic. But more globally, what I'd like to do is ask your allowance to allow me to do more breadth than depth so that I can really focus on telling a story. I will also take the liberty of showing our own data, but interspersing similar data or related data from others, again, with appropriate referencing. And I'll take the liberty to jump between different study populations relatively frequently. And of course, I'm open to questions about the depth of these studies or the populations as needed as questions arise after the talk. So to begin, I think most everybody on this presentation will recognize this slide, which was very important for our field, work that was put together to actually define what we mean when we mean chronic kidney disease. Published in 2002, the KDIGO guidelines that characterized the stages of chronic kidney disease largely by the severity of eGFR or other known damage at the earlier ranges of CKD. And this was really integral for allowing us to discuss chronic kidney disease from one paper to the next or one research study to the next and make sure that we were comparing like patients. Like things that are great but are just starting out, this has, of course, since been advanced. And the largest way that this has been advanced, of course, is because of the addition of albuminuria as an additional measurement of kidney function. And really that work is driven by this seminal paper published by Dr. Astor that used a very large study population within the CKD Prognosis Consortium and evaluated eGFR and risk of end-stage renal disease on the left. And of course, at the bottom in this meta-analysis, you see a very strong relationship of lower eGFR with risk of end-stage renal disease that will not surprise anybody in the audience. But more importantly was the data presented on the right side of this figure, which again, through this very large combined data set, really demonstrated definitively that worsening proteinuria or albuminuria was also extremely strongly associated with risk of end-stage renal disease, independent of eGFR or other risk factors. Based on these data, the KDIGO group in 2013 revised the original CKD staging criteria for chronic kidney disease to this heat map that we've also all become very familiar with. Again, we now have stages of eGFR, as can be seen on the left, with worsening eGFR going through increasing stages of risk, and worsening albuminuria horizontally. And this heat map allows us not only to define the severity of eGFR and albuminuria, but once chronic kidney disease is diagnosed, it also allows us a way to define risk for adverse outcomes, whether they be end-stage renal disease or cardiovascular disease. And yet, if you step back, one realizes that both eGFR, largely based on creatinine or sometimes cystatin C, and the urine albumin to creatinine ratio primarily focus on the health of the glomerulus. eGFR primarily for filtration or glomerular function, and albumin to creatinine ratio really is glomerular injury. So we were struck largely from our clinical observations that often when individuals had relatively preserved kidney function, but required a kidney biopsy, either in the setting of a kidney transplant or for diagnosis of de novo chronic kidney disease, we would not infrequently see biopsies such as the image that you're seeing on the right, where the eGFR remains relatively preserved and the proteinuria may not be so severe. And we were quite surprised to see the severity of tubular atrophy and tubulointerstitial fibrosis. And we know that, that from biopsy studies, whether looking at, again, kidney transplant patients, patients with lupus nephritis, patients with IgA nephropathy, that the severity of tubular interstitial fibrosis on biopsy is among the strongest risk markers for risk of loss of kidney function and end-stage renal disease. The finding that we often see tubulointerstitial disease that can be moderate to severe, despite the fact that kidney function is based on eGFR remains preserved, was really quantified to some degree by this important study that was published by Dr. Rule in the Annals of Internal Medicine. Dr. Rule had a unique opportunity in that his center had collected over 1,000 individuals who were healthy kidney donors at the Mayo Clinic. And all of these individuals had measured GFR prior to transplant. And at the time they went to the operating room to donate their kidney, a wedge biopsy was done, providing pathologic data that allowed investigation of the pathologic findings in these relatively healthy individuals and relatively healthy kidneys. And perhaps not surprising, as you can see in the table at the bottom, if you quantify the prevalence of interstitial fibrosis greater than 5% on these relatively healthy kidneys, there is a relationship with more interstitial fibrosis with increasing age of these individuals. But what was surprising is that once one accounted for age, there remained no association between the measured GFR and the degree of interstitial fibrosis. Certainly, as patients have more advanced chronic kidney disease and begin to lose eGFR, of course, at some point, the loss of eGFR and the degree of tubule disease are likely to be correlated. But in these individuals with largely preserved kidney function, I think these data really show that these two measures of kidney function, one based on biopsies and looking at the tubulointerstitium, and another, a blood biomarker that estimates GFR, are relatively poorly interrelated. So that led us to ask the question about whether or not there may be a way where one could non-invasively characterize the health of the kidney tubules. And if that were possible, if that in itself would provide prognostic information about risk, whether it is loss of kidney function, mortality, cardiovascular disease, or other comorbidities that we know are strongly related to chronic kidney disease. So if I can frame a few hypotheses that I will address through our talk. Our first hypothesis was that we could, in fact, non-invasively measure tubule health, and that these markers would predict loss of kidney function independent of glomerular markers of kidney disease, by which I mean estimated GFR and albumin to creatinine ratio. Secondly, we hypothesized that these tubular health markers might also predict CKD-related complications independent of these glomerular markers of eGFR and albumin to creatinine ratio. And then thirdly, we had an aspirational hypothesis with the hope that ultimately, if we were successful, that these tubular markers may allow differentiation of different types of causes of creatinine rise. Perhaps they might ultimately allow differentiation of, for example, acute interstitial nephritis versus glomerulonephritis, which of course could both raise creatinine, but may do so through very different pathways. Or we might be able to differentiate when creatinine is elevated for hemodynamic reasons and prerenal azotemia versus intrinsic kidney damage. So I'll work through each of these hypotheses and show you some data in support of each. So let's begin with the first hypothesis here, looking at tubule health markers and loss of kidney function over time. So most of the data I'll show you today stem from a research grant that was supported by the National Institutes of Diabetes and Digestive and Kidney Disease. We came to the NIDDK with these hypotheses and were fortunate enough to be supported by an R01 grant. And we leveraged data that were available to us within the SPRINT trial. And so since much of this talk will utilize the data from the SPRINT trial, I thought I would begin by a quick summary of this trial. I think many of you will be familiar with it as well. SPRINT is a recently completed randomized clinical trial that recruited just over 9,300 individuals that were all hypertensive and evaluated whether randomization to an intensive reduction in blood pressure to a target less than 120 versus a standard blood pressure target of less than 140 would prevent development of chronic of cardiovascular disease as its primary endpoint. Because of the strong relationship of both blood pressure and cardiovascular disease with chronic kidney disease, the SPRINT trial actively sought to recruit patients with chronic kidney disease, defined as an eGFR less than 60 and as low as 20 milliliters per minute per 1.73 meters squared. I have some of the key characteristics on the left. Their mean age was 68. Again, because this was a hypertensive trial, all of these individuals were hypertensive. All were selected for having higher cardiovascular disease risk, which could be either known prevalent cardiovascular disease, a high Framingham risk score, the presence of chronic kidney disease, or being older than 75. And again, with the work to recruit individuals who had chronic kidney disease, in the end, almost 30% of this trial population had an eGFR less than 60, which constituted just over 2,500 individuals. And it's these 2,500 individuals that were the sample that we used for the data that I'll show you today. So all of the individuals we're looking at had an eGFR less than 60 in this trial. Now, we thought for some time about biomarkers that might be useful and accessible primarily through the urine to reflect injury within the kidney that might also give us different insights to what's happening in the kidney. And I have quite a long list here, and I won't address all of them. I think, again, many of these biomarkers may be known to many of you who are working in kidney disease. But we selected some of these as markers that would give us insights to kidney tubule injury on the left and tubule function on the right. And while more work has been done looking at markers of kidney tubule injury, both in the setting of acute kidney injury and to some degree in the setting of chronic kidney disease, we were equally interested in whether we could characterize abnormalities in how the tubules were functioning and what that might tell us about kidney disease prognosis. And so I'll try to keep apart injury and function in two large categories as I move through the remainder of my talk. And we'll come back to some of these biomarkers in more detail. So as we started our work, other groups were doing similar and parallel work that was quite important. And many of these biomarkers that primarily reflect injury to the kidney tubules had been studied, again, initially to see if they could predict prognosis about acute kidney injury earlier than creatinine or the consequences of acute kidney injury. And shortly thereafter, they began to be studied in outpatients, either looking at risk of incident chronic kidney disease or among individuals with chronic kidney disease with risk of CKD progression. This study that I've highlighted here is work from Dr. Xu and his group in San Francisco within the biomarker consortium, which I think was a very important paper in this topic because, again, it focuses on outpatients within the chronic renal insufficiency cohort that all had chronic kidney disease at baseline and had very good adjudication and follow-up for development of CKD progression and end-stage renal disease. And it was also among the first studies that actually measured multiple injury biomarkers at the same time. And you can see in these main models that when the relationship of these biomarkers with risk of CKD progression defined as a halving of eGFR from baseline or the development of end-stage kidney disease, while these biomarkers were associated with CKD progression in unadjusted models, when these models were adjusted for the very reasonable risk factors that you see listed below, these associations were attenuated and rendered no longer statistically significant. And I'll mention here for the first time that these models are also adjusted for albumin to creatinine ratio and estimated GFR. Some might argue that that's perhaps over-adjustment because that's adjusting for other aspects of kidney disease at baseline. But of course, the clinical question here is whether these additional urine biomarkers of tubule injury would help provide prognosis above and beyond what the clinician has at the bedside with eGFR and albuminuria. So interestingly, despite studying 3 separate markers, well-known markers of tubule cell injury, in the Crick cohort, there was no independent relationship of higher urine concentrations with these biomarkers of injury with loss of kidney function over time. So in our work then in the SPRINT study, we began by looking at a similar question. Again, here I'm showing you adjusted models, again, adjusting for demographics, which intervention arm the studies were randomized, urine creatinine to adjust for tonicity, other CVD risk factors, and again, albumin to creatinine ratio and the estimated GFR. And on the left here, I show you the 5 biomarkers that we had measured in the urine at the baseline visit of the SPRINT study. And all of these mark different aspects of kidney tubule cell injury, inflammation, and repair. And very similar to the findings in the Crick study, once more here, higher urine concentrations of these markers of injury were not independently associated with linear decline in eGFR as the endpoint in this model. But I want to characterize that in relation to the 3 biomarkers that we studied that evaluated tubule function. Again, these also measured at the baseline visit of the SPRINT study. And here, unlike the markers of injury on the left, 2 of these biomarkers were indeed associated with more rapid loss of kidney function over time. Taking these in reversed order, the first was alpha-1 microglobulin, which I'll describe to you in the next study. Higher urine concentrations of alpha-1 microglobulin were independently associated with more rapid decline in kidney function. And in contrast, uromodulin, another biomarker of tubule function, was also associated with loss of kidney function, but the direction was in the opposite direction. So here, lower concentrations of uromodulin were associated with more rapid decline in kidney function over time. And once more, these associations are independent of eGFR or albuminuria or the other risk factors that you see listed below. Okay, so just one slide each on these 2 biomarkers. So the interest that we had in alpha-1 microglobulin and beta-2 microglobulin initially when we measured them for our study was to see if they may be useful as a marker of proximal tubule reabsorptive capacity. Both of these are small proteins that are found in the bloodstream and are thought to be freely filtered at the glomerulus, similar to creatinine. But unlike creatinine, these 2 proteins are avidly reabsorbed at the proximal tubule, such that in most healthy individuals, there's very small concentrations of these proteins ultimately in the urine. And we had preliminary data evaluating these biomarkers in individuals with HIV who were treated with tenofovir, a known proximal tubule toxin, showing that treatment with tenofovir appeared to increase the urine concentrations of these proteins. And again, when tenofovir was held, these biomarkers would go down in the urine, suggesting that perhaps they were useful markers of proximal tubule reabsorptive capacity. And so the idea here was to characterize the kidney tubules' function in terms of their ability to reabsorb proteins that are filtered into the urine. So once more, the idea is that if there's a problem with reabsorption, less of this would be reabsorbed, and the concentrations of alpha-1 or beta-2 microglobulin would be anticipated to be higher in the urine. The other protein that I mentioned several slides back is uromodulin. This is a well-known protein in our field. It's also known as Tom Horsfall protein, and it's well known as the most abundant protein in the urine in individuals without proteinuria, without glomerular disease. And the literature around uromodulin is quite vast. There's a lot of discussion about the function of this protein. What's clear is that certainly genetic abnormalities in uromodulin can lead to kidney disease. It's the genetic gene that's altered in medullary cystic kidney disease. The other thing that's very useful about it for the purpose of this study is the only part of the body that expresses uromodulin is the thick ascending limb of the loop of Henle in the distal convoluted tubule. So it's a protein that's very specific to generation in the tubules. It's known that it's located on the luminal surface, And it's thought that it interacts with this gel-like membrane on the inside of these tubules in the cilia. And it's thought by some investigators to be important for prevention of adherence of bacteria and prevention of E. coli. It may be also important for generating a water barrier, if you will, to make the thick ascending limb of the loop of Henle impermeable or less permeable to water in this part of the nephron. And so we were interested in this protein for several reasons. Again, it is only produced in the tubules themselves. And we were intrigued by data such as these here, published in C. Jason several years ago, showing that greater urine concentrations of uromodulin on the y-axis were associated with larger kidney volume and larger kidney length. And we had preliminary data in other studies showing that higher urine concentrations of this biomarker in itself seem to be associated with risk of CKD progression. And so perhaps this is a useful protein to characterize the kidney's reserve in terms of its size here, and perhaps its function in terms of protein generation and protection from infection. So again, another very useful and interesting aspect of urine uromodulin is that unlike albuminuria or alpha-1 microglobulin or NGAL, in this case, higher urine uromodulin appears to be a good thing rather than a bad thing. And so statistically, it's quite useful because it becomes clear that you're not marking general proteinuria, but rather something that's specific. On the heels of these interesting findings of two biomarkers that seem to characterize kidney tubule cell function with more rapid loss of kidney function, an investigator in our group who's primarily interested in future risk of acute kidney injury raised an interesting hypothesis that we wanted to follow. And the idea here is that perhaps AKI could be useful similar to a kidney stress test. The idea is that, of course, routine creatinine-based eGFR is not necessarily the maximum GFR that individual can attain at a given level. And there have been studies that demonstrate this with IV infusion of amino acids or high protein loads, showing that patients can actually increase their GFR in response to protein stimulus. And maybe the analogy is something like a resting heart rate or a resting tidal volume, that the measurements that we get at rest do not necessarily give us a true sense of the kidney's capacity. And other than doing infusions or high protein loads, it's quite hard to know what the kidney's true capacity is. In the setting of the SPRINT trial, we thought that perhaps AKI was a useful marker of a kidney stress test, meaning if one acutely lowers a patient's blood pressure with more intensive blood pressure lowering, and then that individual has an additional stressor, whether it's an acute illness or bleeding or diarrhea, why is it that some of those individuals may develop acute kidney injury while others do not? And so we thought about this really as a kidney stress test, if you will. And so the hypothesis here was whether or not having evidence of tubule cell injury or dysfunction at the baseline visit of SPRINT would tell us something globally about the health of that kidney. And if individuals seem to have abnormalities there, whether they would be at higher risk of acute kidney injury during SPRINT follow-up, even though these biomarkers were measured at the baseline visit where individuals were coming in at times of relative health without acute stressors. And what Dr. Bullen in our group found and recently published in Kidney International, the main findings of his paper are summarized here. Again, looking at the 5 markers of tubule cell injury that we measured at the baseline visit of SPRINT, none of these were independently associated with risk of future acute kidney injury. And in contrast, once more, urine uromodulin and alpha-1 microglobulin, as measured at the baseline visit of SPRINT, were again relatively strongly and independently associated with future risk of AKI, independent of eGFR and albuminuria. So once more here, the biomarkers that seem to mark function of the kidneys rather than injury at times of health seem to be more strongly associated with AKI in this setting, similar to eGFR decline. Now, of course, there are other markers of tubule cell function, and some of these may be closer to clinical practice. There are several that we're interested in measuring in future work that we have not yet characterized within SPRINT or our other studies. But I wanted to just bring up two studies that I think are similar in theme and show that others are thinking in the same way. There are now several papers that have compared the relationship of CO2 concentrations on a blood specimen or on a blood gas with risk of CKD progression. This paper that I've chosen here was from a large study in South Korea that studied over 2,700 kidney transplant recipients, showing again that lower CO2 concentrations on a standard blood test was strongly associated with future graft loss, again independent of EGFR, albuminuria, and anti-rejection medications, other than other risk factors. And on a similar theme, Dr. Raphael and his group recently measured urine ammonium in the ASK trial. And of course, urine ammonium is produced by the proximal tubules and then combined with hydrogen in the distal tubule as the kidney's main mechanism of excreting acid. And once more here, individuals that had lower urine ammonium concentrations, perhaps another marker of the kidney's ability to generate and regulate acid-base control, were at higher risk of dialysis or death. And so across several biomarkers looking at the function of the kidney tubules, there appears to be a consistent signal with higher risk of loss of kidney function. So what about other CKD-related complications? And here I'll focus primarily on cardiovascular disease. Again, cardiovascular disease was the primary endpoint of the SPRINT trial. And so we had the opportunity to have very good capture of the CVD events that occurred after the baseline visit in SPRINT. And these were all adjudicated by pre-specified criteria and a panel of experts that were adjudicating these endpoints in the same way. Once again, we had decided to measure the biomarkers that I'd already showed you in about 2,500 individuals with chronic kidney disease in baseline. So the data I'm showing you are limited to those individuals with chronic kidney disease. And among these individuals, there were 305 CVD events during the approximately 3.5 years of follow-up that we had after the baseline visit in SPRINT. So once again here, we have a similar table. We again have the injury biomarkers on the left, and on the right, we have the 3 biomarkers of tubule cell function, except now the endpoint is cardiovascular events. And I'm showing you the hazard ratios and 95% confidence intervals as compared to the linear EGFR decline that I'd shown you in the previous studies. But the message is otherwise quite similar. Once more here, despite measuring 5 different biomarkers of tubule cell injury at the baseline visit of SPRINT, we found no association of any of these biomarkers with risk of incident CVD in adjusted models once accounting for EGFR, albuminuria, and the other risk factors that you see listed. In contrast, once more, these 2 biomarkers that characterize tubule cell function were each independently associated with risk of incident CVD. And again, the direction of these associations were similar as before. Higher urine alpha-1 microglobulin was associated with higher risk of cardiovascular disease, and lower baseline urine uromodulin was associated with higher risk of cardiovascular disease during follow-up. So once more here, it seemed that the function of the kidneys, rather than characterizing their injury, seemed to give more prognostic information in regards to risk of cardiovascular disease. Dr. Garamella, who led this work for our group, published this work in the European Heart Journal last year, and put together this very nice slide that I wanted to depict because it gives you some sense of the strength of these associations. So on the bottom here, you can see that we're looking at EGFR on the left, urine albumin here in the blue, alpha-1 microglobulin in the yellow, urine uromodulin, this is actually 1 over urine uromodulin to make the risk look in the same direction to compare strengths of association, and ultimately beta-2 microglobulin. And in this model here, all of these biomarkers are adjusted for all of the variables I showed you on the previous slide, as well as the other urine biomarkers. And the 2 points that I'd like to make in this slide are that both alpha-1 microglobulin, in this case shown as per doubling, and higher or lower urine modulin per halving, if you will, were about similarly strongly associated with risk of incident cardiovascular disease. And in fact, by comparison of point estimates, slightly stronger than albuminuria, even though these biomarkers were already adjusted for albuminuria. So it gives you some sense that these biomarkers are actually giving relatively strong associations with cardiovascular disease above and beyond the other risk factors. The second point is that EGFR had a very interesting signal here. Of course, lower EGFR was associated with risk of cardiovascular disease in SPRINT. But when we adjusted EGFR for these risk factors, these urinary tubule function biomarkers, the EGFR signal was essentially extinguished and brought all the way down to 1, suggesting that these markers are in fact telling us something about the health of the kidney and capturing some of the effect that we typically get with EGFR. But these remain independently associated with cardiovascular disease and appear to attenuate the association that we see with EGFR, at least in these data in SPRINT. So ultimately, we would love to have additional tools to characterize how we treat patients and how we diagnose different causes of kidney disease. And so we have an aspirational hypothesis here, one that is in its infancy and is certainly not definitively proven. But I wanted to share some exciting data about how the use of different biomarkers might be used moving forward to actually help us in diagnosis and prognosis in our patients. And so what I'll do to begin here is, again, use SPRINT data. In this case, we have biomarkers, again, in all 2,500 with chronic kidney disease at baseline. And as we designed our study, we elected to make repeat measurements in 1,000 individuals. And these 1,000 individuals were selected at random among the 2,500 individuals that we had at baseline. So they too all have chronic kidney disease at baseline, but represent a subsample of the 2,500 we had at the beginning of the study. And we did this at 1-year follow-up. So one of the things that is interesting and important to know about the SPRINT trial that I think many of you will be aware of is that while there were dramatic improvements in the primary endpoint in the SPRINT trial in terms of intensive blood pressure, lowering the risk of incident of future cardiovascular disease with a 25% risk reduction, and similar effects in terms of reducing all-cause mortality, and more recent data suggesting that intensive blood pressure control may also be very helpful for preventing mild cognitive impairment. Certainly, these hazard ratios here are all consistent in direction for very important clinical endpoints in older adults. But what was also observed in the SPRINT trial was that despite these improvements in these important clinical endpoints, there was higher risk of incident chronic kidney disease and higher risk of acute kidney injury with intensive blood pressure lowering. And it's been difficult for many of us in nephrology to square these two and try to understand what is best for individual patients if we're potentially giving benefit in one important endpoint, but God forbid, worsening their kidney function or their kidney function risk in the other. So among individuals with chronic kidney disease in SPRINT, it's important to look at the pattern of how EGFR changed during the course of this trial. And what I've tried to highlight in the red box on the left here is that the change in EGFR that occurred between these two arms actually primarily occurred early in the study. And as you can see, this divergence in the first 6 months, which to me suggested that this reduction in EGFR might primarily be a hemodynamic effect of more intensive blood pressure lowering, and might suggest that in fact this is not intrinsic kidney cell injury, but instead, again, maybe a hemodynamic effect. So we realized that with these markers that we had measured in the urine repeatedly, some looking at actual intrinsic cell injury in the kidneys and others looking at tubule cell function, could we actually differentiate whether or not there is intrinsic injury occurring in these individuals who are in the trial? And this work was led by Rakesh Malhotra, another assistant professor in our group. And I guess the larger research question is really what happens to the kidney during blood pressure lowering. And our hypothesis, again, is that EGFR generally follows the blood pressure, that this is a hemodynamic change in EGFR and would not be associated with intrinsic cell injury. Based on the data we had, we're limiting this again to individuals with EGFR less than 60 who started in the study. And we're going to compare the 1-year changes in EGFR, albuminuria, and then the 8 markers of tubule cell function and injury that I've already introduced to you earlier in the study, or earlier in the talk. So the first observation we made, which I think is very important clinically, is here what we did is we simply took the individuals with chronic kidney disease that were in SPRINT and we characterized the magnitude of their change in blood pressure during the trial. So you can see we have 5 quintiles here, and this is limited to the intensive arm of the SPRINT trial. And so despite the fact that these individuals should have had a reduction in blood pressure, you can see that about 1/5 of them actually had no change or perhaps even an increase in their blood pressure. And in the other extreme, some individuals had quite a dramatic reduction in blood pressure. But by stratifying by quintiles, as you can see here, and then characterizing the associated change in EGFR, you can see this very linear relationship where if you had very little change in blood pressure, there was very little change in EGFR. And in parallel, if you had larger changes in blood pressure, that was accompanied by a larger decline in blood pressure. Larger decline in EGFR. Again, I think this is supportive data of a hemodynamic effect. Looking at the roughly 1,000 individuals that we had repeated urine markers of tubule function and injury in, this table here shows you what happened to their EGFR on the left and their albuminuria in the next bar here. And on the y-axis, we're comparing the effect change in the intensive arm that had intensive lowering of blood pressure versus those in the standard arm. And so the first bar shows you what I've already shown you in the larger population, that in these 1,000 individuals, those that were in the intensive arm also experienced a roughly 8 milliliter per minute decline in EGFR during the first year of the study with intensive blood pressure lowering. At the same time, despite a reduction in EGFR, which might suggest a worsening of kidney function if this was intrinsic, these individuals had a dramatic reduction in the quantity of albuminuria, roughly a 30% reduction in EGFR, a reduction in albuminuria in the intensive arm, despite a reduction in EGFR. Right? So again, these 2 markers are telling us something different about whether or not the kidney is perhaps injured or improving. EGFR is getting worse, albuminuria is getting better. What about the other markers that we evaluated? Well, the main message that we found in the study is that across these 8 markers of tubule health, none of the biomarkers were worsened in individuals that were randomized to the intensive arm of the study. None of these markers, for example, if you want to look at NGAL or KIM1, none of these markers of tubule cell injury were increased with intensive blood pressure lowering. So across a panel of markers, we could not find any evidence that the tubules were being damaged with intensive blood pressure lowering. So again, I think this is supportive data that likely the decline in EGFR observed in this trial may be primarily driven by hemodynamic effects. You'll see that 2 of the biomarkers were actually statistically significantly reduced in the intensive arm of the study. Now, this was not pre-hypothesized, but I think provides important complementary data for the hypothesis that we're putting forward here. And I want to remind you that both of these biomarkers that were reduced with intensive blood pressure control were these markers that I introduced to you before, alpha-1 microglobulin and beta-2 microglobulin. These were the markers that were freely filtered at the glomerulus and that we had measured because we thought that they would give us insight into the reabsorptive capacity of the proximal tubule. But of the 8 biomarkers that we measured, they're the only 2 that are actually filtered at the glomerulus. And so it's possible that if there's a hemodynamic effect that reduces blood pressure or the filtration at the glomerulus, that would also reduce filtration of these two biomarkers, and that we're picking that up in the urine with our biomarker panel. This is a corollary slide to what I showed you previously with the changes in eGFR in relation to the changes in blood pressure. So in this side here, what we've done is I've characterized the individuals that, based on quintiles of how much decline in eGFR they had in the first year. And in the green circles here, you see the individuals that had the largest decline in eGFR over the first year. And in all three of these cases of these biomarkers, whether it's albumin to creatinine ratio, beta-2 microglobulin, or alpha-1 microglobulin, the individuals that had the largest decline in eGFR actually had the largest reductions in the quantity of these biomarkers in the urine. So again, suggesting a hemodynamic effect. And of course, the opposite was also true, that those with the smallest changes in eGFR actually had the smallest declines in urine concentrations of these biomarkers. So, one exciting part of Dr. Malhotra's work in our group was the idea that this panel of biomarkers may ultimately allow us to differentiate hemodynamic causes of eGFR change from intrinsic cell injury. And again, here I've moved the box, but we have 4 markers that are all at least partially influenced by glomerular filtration and all decreasing in response to what we believe is a hemodynamic effect of the kidney. Whereas we have other biomarkers here on the right that mark tubule cell damage or intrinsic injury within the kidney, and none of these were altered in the 1,000 individuals that we're studying here within the SPRINT trial. So of course, we have ideas and additional hope to characterize this panel of biomarkers in other settings to see if they can characterize the causes for eGFR changes. And we believe it'd be a very useful tool if it could be used clinically when the creatinine bumps, to be able to differentiate whether or not that's a hemodynamic effect, a drug effect, or perhaps something more ominous where there's intrinsic injury within the kidney parenchyma. I want to acknowledge some exciting work that other groups are doing as this talk goes along. And I was very intrigued and excited about this study recently published that I wanted to bring your attention, which I think has a similar theme, although the design of the study and the biomarkers are in fact a little bit different. So these investigators enrolled about 250 individuals, and all of these individuals had kidney biopsies for acute kidney injury. And the biopsies were reviewed by 3 independent pathologists, and all 3 had to agree on a diagnosis of acute interstitial nephritis. So 32 of the roughly 250 biopsies had very clear acute interstitial nephritis. And the investigators hypothesized that they might be able to use urine biomarkers to identify a unique signature for AIN by studying cytokine concentrations in the urine. And in brief, 2 of the cytokines that they studied, urine TNF-alpha and IL-19, were identified as useful biomarkers to differentiate acute interstitial nephritis versus other causes of acute kidney injury that required biopsy. And here you can just see that visually. You can see TNF-alpha on the top panel and IL-9 on the lower panel. You can see the other causes of kidney disease and some healthy controls over here. And you can see that both of these biomarkers were substantially higher in individuals with acute interstitial nephritis, even as compared to ATN, GN, or other causes of kidney disease. And among those that had acute interstitial nephritis, there also seemed to be a dose-response relationship. So if you characterize the degree of interstitial infiltrates on these biopsies from normal, mild to severe, you can see that the concentration of urine TNF-alpha goes up with increasing severity of interstitial infiltrates. Same for IL-9. If there was tubulitis, the same idea, these biomarkers were higher. If there was greater eosinophilic infiltrate, again, a similar story. But again, here, if you characterize the amount of tubule injury, there was no clear signal in these biomarkers, again, suggesting that they give insight into a unique pattern of injury from acute interstitial nephritis. And lastly, and I think moving closer to the clinical arena, they compared the impact of these biomarkers on the appropriate diagnosis. You can see the pre-biopsy clinician diagnosis in terms of what the pathologists actually found, given A1 or an AUC of only 0.62. But when combined with this 2 biomarker panel, substantially improved the area under the curve, suggesting these biomarkers helped tremendously in obtaining the right diagnosis of acute interstitial nephritis. So to summarize, tubulointerstitial damage, fibrosis, and dysfunction, I think are common findings on kidney biopsy. I think they're very prognostically important, and yet, unfortunately, I think we are still blind to these if we rely on eGFR and albuminuria alone, except for the rare instance where we do kidney biopsy. In our work to date, markers of tubule cell dysfunction in particular seem to be particularly strongly associated with CKD progression and cardiovascular disease. I've shown you our data evaluating alpha-1 microglobulin and urine uromodulin. Others are working with serum bicarbonate, urine ammonium, and I think there are yet additional markers that can give us other aspects of what the tubules do that may be very important for defining prognosis and expanding the way we look at the health of the kidney. I think emerging biomarker panels suggest that we can differentiate hemodynamic versus intrinsic causes of creatinine elevation, and ultimately might allow us to differentiate different etiologies of AKI, as in the AIN example. So the way I am thinking about this now, the way that I hope that we might be able to move as we approach this, is that perhaps we can think about a broader assessment of kidney health that assists us in diagnosis and treatment, the same way that we currently use a liver function panel in clinical practice. And I've shown here just my shorthand of how I record liver function abnormalities when I'm rounding with my team. But I want you to stop and think for a moment, if you're a clinician, about what you might think the etiology of liver injury is in a patient who is hypotensive after a hemorrhage, for example, in the ICU, and you see them the following morning with very high AST and ALT, but relatively preserved other abnormalities in their tubule or in their liver panel. This to me would suggest shock liver. And so just by comparing the clinical scenario and the relative concentrations of the biomarkers, we can get insight into the likely etiology of their liver disease. Take another patient that may have obstructive jaundice and has very high total bilirubin and alkaline phosphatase, but relatively preserved AST and ALT. And again, just the pattern of these biomarkers one to the other might give us some insight into what's happening in the liver. And as a third example, take the patient with cirrhosis who has relatively preserved other markers of liver function, but decreased synthetic capacity with a low albumin and an elevated INR. Once more, this panel of biomarkers, comparing them side by side, gives us immediate insight into the likely etiology of their liver disease, just based on blood tests in this case. And so I'm hopeful that we can follow that same pattern and ultimately have a broader assessment of kidney health that will help us improve diagnostic accuracy for the causes of AKI and CKD, might provide us non-invasive methods to improve prognosis, and ultimately might allow us to monitor changes in kidney health over time. For example, to tell us why creatinine is changing, or if we know why and we make a therapeutic maneuver, for example, prednisone for acute interstitial nephritis, that we can actually monitor the response to those therapies without requiring repeated biopsies and know that we're making a difference somewhat sooner. My main message is perhaps it's time that we move beyond serum creatinine and albuminuria and consider a broader assessment of kidney health. And with that, I want to thank you for your attention, and I want to acknowledge my close collaborator and friend, Mike Schlipak, who was a co-principal investigator in this research grant, the generous support we received from the NIDDK, all the trial participants and the other investigators of the SPRINT trial, and our respective institutions. Thank you so much for your attention.